Very good morning to everyone. Thank you, Jagan sir, for a wonderful initiative, and thank you, Sindhu Hospital Management, and warm welcome to Hyderabad Fracture Fixation course. Thank you, chairpersons, and my dear delegates and faculty members. We are very thankful to Jagan sir. Very impressed with Jagan sir. He come back to India, and he got a great academician. India got a great academician, and UK missed a good surgeon. Thank you, Jagan sir, for coming to India, because I was trained initially after training with Guruvarat sir. I moved to UK for training in UK, so I know how life cool is there. Again, came back to India. Thank you, Jagan sir. So the today topic for discussion is peri-prosthetic fractures. So strictly, I will today confined to knee surgery, and there is a paper reported by Talal and et al. There are various factors related to peri-prosthetic fractures. So firstly, it is patient related. Then secondly, it is related to implants. Thirdly, it is related to surgeon. So regarding patient related factors, females are more prone for peri-prosthetic fracture because of osteoporosis. And revision surgery is the independent risk factor. Any revision surgery, surgeons should be very cautious while dealing with revision surgery. And bimodal age distribution has seen like less than 60 years and more than 80 years are prone for 40% more when compared to between the people 61 to 80. And regarding patient specific factors, patients are having comorbidities like diabetes, cardiac problems, even neurological problems like Parkinson's, epilepsy are more prone for peri-prosthetic fracture. And those patients who are using steroids for rheumatoid arthritis also, they will be suffering with osteoporosis. And obesity is also very commonly seen in peri-prosthetic fractures. And most of the time before, introduction of robotics, surgeons very almost either we are not following exactly measurement, exact alignment of the implants, whether sometimes we may keep in varus or valgus. So keeping the implant in varus or valgus also later on leads to insufficient fractures. This is the knee we did for alignment problems. Then we found an insufficient fracture of the unloaded femoral condyle. And regarding implant specific factors, there is a clear interest area of interest between the smaller bone to processes more risk. And robotic assisted surgery these days, whenever we are keeping pins for navigation markers, they are at risk. So surgeons should be very careful while removing them, especially because the same pins will be continuously used for every surgery. At certain point of time, either bone may break or even pin may break. And surgical factors, especially while dealing first 50 surgeries or 60 surgeries, anterior notching of the femur is more common. So if it is notching is more than grade 3, then it may relate it to peri-prosthetic fracture at later date. And malalignment, as I mentioned, more than 5 degrees of varus leads to insufficient fracture of the femoral condyle in later date. And we need a complete thorough evaluation, because most of the time patient will not give a proper history. Whenever I do a surgery more than 60 years or 70 years, I will tell to them that there is a 50 to 60% of patient again coming back to hospital because of fall at home while they are taking steps or while they are going to washrooms, while they are going to temples. There is a high risk of fall. So I clearly tell them at the time of discharge, you should be very careful while going to washrooms. Make sure your washrooms are really dry. And there are various classifications. Neer et al. And Robotic classifications are widely used. And even there is one more classification, new unified classification. It's simple. Type A means extra-articular fracture. Type B means it's through the bed. Type C means it is above the implant. Type D means it is interprosthetic fracture between the hip implant and the knee implant. And Type E means there is a poly tibia fracture and with femur fracture. Type F is also there, which is like bone facing the articulating surface of the hemiarthroplasty. Here it is a type A fracture. Type A, it is like involving extra-articular, where it is involving the medial epicondylar, lateral epicondyle. If it is undisplaced, just hinge knee brace is sufficient. This fracture is type B, and femoral component is completely loose, so revision surgery is mandatory. So when it comes to another classification, Robotic classification, where type 1 is like non-displaced fracture, implant is stable. Type 2 is displaced fracture, also implant is stable. Type 3 is displaced fracture with the implant is also loose. So it comes to tibia, there are 4 types of fracture. Type 1 is tibial plateau, type 2 is adjacent to the stem, type 3 is distal to the processes, and type 4 is tibial tubercle. Again subdivided into type A, B, C. A is well fixed to tibial implant, B is loose, and type C is intraoperative fractures. All intraoperative fractures like type sub C should be immediately fixed with the plate or revision implant, and whenever there is a loose tibial implant, always require a revision surgery. Type 4 fracture, loss of extension function, tibial tubercle fracture, either they need to go for a osteocyte reconstruction or revision arthroplasty. And comes to last third bone, like that is patella. There are type 1 fracture where fracture is not involving the implant. Type 2 is where fracture is involving the implant also. Type 3A means inferior pole of patella. Type 3B is non-displaced fracture with intact patellar ligament. And type 4 is lateral fracture dislocation of patella. Patella is very simple to manage. Type 1 is if intact, extensor mechanism is intact, conservative management. Type 2 is stable implants, tension band wearing, loose implant, revision. Type 3 is type 3A, well fixed implant, treat according to patella tendon, how we manage. And type 3B is stable, conservative, unstable, revision. And these are some cases we did at Onus. This patient underwent bilateral hip replacement surgery and bilateral knee replacement surgery. And unfortunately, while going to temple, she had fall and leading to Peri-Prosthetic fracture. So this is the 5th surgery she underwent, and we revised. Patient specifically wants Johnson and Johnson, so we revised distal femoral replacement. Many patients are worried that post surgery patients may not walk after revision surgery. So unfortunately, in India the acceptance rate in revision surgery is very low. I was trained in Germany, endo clinic, where they undergo extensive revision, 5th revision, 6th revision, 7th revision. When we look at OT list, you see here 7th revision, 8th revision we see there. In India, once we tell even primary surgery, second surgery means over. They think that we are bedridden. You see this patient underwent bilateral hip, bilateral knee, again had fall, and within 14 days he was walking like this. So thanks to companies where they are giving the best implants, with we are able to restore the normal kinematics of the hip and knee. Within 15 days she attended her daughter's marriage. The other patient, this is specifically I kept. Most of the time, whenever peri-prosthetic happens inside operating room, surgeon should be very, very careful while dealing with the revision surgeries, because already extremely osteoporotic and extreme bone loss will be there while doing the revision surgeries. And this patient underwent 3 times surgery. I did 4th time. Outside they underwent 3 times and I did 4th time. So when while I am keeping the poly implant at the final step, the assistant surgeon was deviating. So less than 1 second, we just banged the poly, then medial epicondyle fracture. Imagine, so surgeons should be very careful at the throughout while cementing and doing implantation, especially. So extremely we should be very careful. And fortunately nothing happened. We were having a distal radius plate, immediately we fixed that. This is the other case our team Dr. Karthik did. So femur fracture with stable implant. So he did a DFN, distal femur nail, through the implant. So this is the bilateral plate, both sides, middle and lateral. And this is the another case not related to peri-prosthetic fracture. This is the case we did at Onus, and this patient extremely done very good, very well. First 1.5 years, very severe valgus knee, extremely well aligned with robotics, and she went to temple again, had fall, but she is not giving history of any fall. But when we opened the knee joint and everything, there is a clear-cut MCL tear, and we never recognize MCL tear for at least 1 year. Usually, if it is intraoperative, within 3 months they will fail. So there is a dictum rather than if you conservatively treat any MCL tear, they will bound to fail within 3 months. So patient come after 1.5 years means it's there is a clear-cut history of fall. So implant we opened, we thought that there is a implant loosening, all that stuff. We were prepared for revision surgery. So we reconstructed the MCL ligament. So patient extremely doing good. And thank you. So we warmly welcome to our RoboCon 4.0. This is the future of orthopedics, and all hospitals by 2030 will have robotics. Whether you like it or don't like the statement, even recently we are seeing interviews, doctors will be replaced by robots. Doctors will become like more of caregivers and decision makers in the future. By 2030 or 35, most of the things will be done by robots. Doctors will be giving feedback. And once again, we warmly welcome to, this is like we are going to conduct on November 27th, 29th. Venue not yet decided. This is the future of orthopedic surgery, robotic surgery. Future will be AI, virtual reality, augmented reality, and robotics. Thank you very much, all the delegates. Thank you, Jagal sir. Thank you, chairpersons. If you have any questions regarding peri-prosthetic fracture, you can ask.